Hey everyone, welcome to this explainer. Today we're diving straight into a massive, preventable threat, decubitus ulcers. We know how crucial clinical vigilance is to stop these literally dead in their tracks, so we're going to skip the long intro and get right into the facts. Here is our clinical roadmap for today. We'll be covering what a decubitus ulcer actually is, the risk factors and pressure points, the pathophysiology cascade, the 4 stages of wound progression, how we assess them using the Braden and Norton scales, and finally, prevention and treatment methods. Let's get to it. All right, section 1. What is a decubitus ulcer? Let's quickly define exactly what we're looking at here. So a decubitus ulcer, what we commonly call a pressure ulcer or a bed sore, it's definitely not just a surface scratch. It's a localized injury to the skin and the underlying tissue. This almost always happens right over a bony prominence as a direct result of prolonged, unrelieved pressure. Simply put, it's an injury of sustained compression. Moving on to section 2, risk factors and pressure points. This is where we map out the vulnerabilities. Now take a look at these 8 key risk factors. Right at the top, you've got friction and shear, which, as we know, physically tear at those skin layers. But we really need to look deeper. Think about impaired sensory perception and physical mobility. If a patient can't feel the damage happening or literally can't move to relieve the pressure, they're sitting ducks. Throw in malnutrition, excessive body weight, advanced age, and chronic conditions like diabetes or cardiovascular disease, and well, you've got a perfect storm. The scary part? Irreversible tissue damage can kick off in just 2 hours. Literally, just 2 hours. And a patient's vulnerability really depends on how they are positioned. If someone's in a supine position, flat on their back, the sacrum and coccyx take the absolute worst of it, with secondary hotspots on the heels, elbows, shoulder blades, and the back of the head. Now, if they're prone, lying on their stomach, the anterior knees or the patella take the brunt of that pressure. And if we flip them to a lateral position on their side, the greater trochanter of the hip becomes the prime target. Memorizing these specific anatomical pressure points is basically your first line of defense. Okay, section 3, the pathophysiology cascade. Let's look at the actual biological mechanics. It's absolutely crucial we understand this exact sequence. Step 1, physical pressure exceeds the normal capillary pressure. It's that simple. But once you cross that threshold, you hit step 2, the physical occlusion and tearing of small blood vessels. And that blockage? It leads right to step 3, reduced tissue perfusion. The cells are literally starving for blood. That triggers step 4, ischemic necrosis, where that starved tissue starts to die off, which finally lands us at step 5, the actual formation of the pressure sore. It is this silent, ruthless domino effect that inevitably ends in tissue death if we don't step in to relieve that pressure. Which brings us to section 4, the 4 stages of wound progression. So, stage 1. This presents as non-blanchable redness of intact skin. It's only involving the epidermal layer right now, presenting with that non-blanchable erythema, usually right over one of those bony prominences we just talked about. You might also spot some discoloration, warmth, swelling, or the patient might report pain. Now, because the skin is actually still completely intact here, this is your golden window. It's the critical time to intervene before permanent damage is totally locked in. If you miss that window, it rapidly escalates into stage 2. Here we're looking at partial thickness skin loss. The damage has officially breached the epidermis and the dermis. It usually presents as a shallow open ulcer, maybe an abrasion or a fluid-filled blister with a really red-pink wound bed. Now, you won't see any slough here, but make no mistake, it is an incredibly painful, shallow open wound. And it gets worse. By stage 3, we're dealing with full thickness skin loss. At this point, the epidermis, dermis, and subcutaneous tissues are all compromised. You might even see subcutaneous fat peeking out right in the wound bed. Luckily, the deep structures like bone, tendon, and muscle are still hidden. But here's the kicker. That subcutaneous layer has a pretty poor blood supply, which means a stage 3 ulcer is notoriously slow and difficult to heal. Finally, we hit stage 4, full thickness tissue loss. This is the deepest, most dangerous stage of all. The ulcer now extends straight down into the muscle, the tendon, or it might even fully expose the bone. The structural damage at this level is massive. And to be blunt, it poses a severe, immediate threat to the patient's life. And stopping that progression early, absolutely vital. Because if left unchecked, the complications of these ulcers are just terrifying. We're talking cellulitis, deep bone and joint infections, systemic sepsis, and eventually, even cancer. It's wild to think that a simple, unchecked pressure point can spiral into a full-blown systemic crisis, but it absolutely does.
All right, section 5, assessment tools. Let's look at the Braden and Norton scales.
Our first gold standard tool is the Braden Risk Assessment Scale. This scores patients across specific categories: sensory perception, moisture, activity, mobility, nutrition, and friction. We tally it up, and that aggregate score tells us their risk level. For instance, a score between 19 and 23, they're in the clear, no risk. But if that score drops below a 9, that patient is firmly in the very high risk bracket. It's just a fantastic, quick numeric way to flag extreme vulnerability before things go south. Alternatively, you might use the Norton subscales. This gives us a rapid structural breakdown across 5 categories, scored from 4, which is the best, all the way down to 1, the absolute worst. It looks at physical condition, mental condition, ranging from fully alert down to a stupor, activity levels, mobility, and continence. So think about it. If a patient is completely bedbound, in a stupor, and incontinent, their Norton score is going to plummet. That low score is a giant red flashing light for the caregiver that this patient is at massive risk for skin breakdown. Almost at the finish line. Section 6, Prevention and Treatment Methods. How do we actually stop the damage? Now, as the medical consensus always tells us, bedsores are 1,000 times easier to prevent than to treat. So our prevention protocols have to be completely rigorous. We're talking healthy nutrition and lifestyle changes, like getting them to quit smoking or do some light exercise if they can. But the big one, repositioning. It is absolutely mandatory. You have to shift a bedridden patient every 2 hours, and if they're in a wheelchair, every 15 minutes. No exceptions. We also heavily rely on support cushions and specialized mattresses to offload that pressure. Throw in meticulous wound cleaning with saline, strict incontinence management, debridement of dead tissue, the right dressings, oral antibiotics, and honestly, relentless caregiver education to make sure the whole team is on the exact same page. But what if a wound does hit those advanced stages? Well, our treatments have to escalate just as fast. We move way past basic dressings and step into major surgical repair. We're talking tissue flaps, extensive plastic surgery, hyperbaric oxygen therapy, and even the topical use of human growth factors to literally try and force that destroyed tissue to regenerate. It turns into a massive, incredibly expensive, and deeply painful clinical undertaking for everyone involved. So we've walked through the strict definition, the pathophysiology cascade, those 4 dangerous stages, the Braden and Norton assessments, and the rigorous prevention and treatment protocols. I want to leave you with this final thought. Knowing just how rapidly a stage 1 ulcer can cascade into severe, life-threatening tissue loss, what proactive assessment steps are you going to implement for the vulnerable individuals in your care today? Decubitus ulcers are a fierce enemy for sure, but the power to stop them lies entirely in your proactive observation. Thanks for joining me for this explainer, and keep learning.